So hi guys, hope I'm live and audible. So welcome back to the Reed Harrison series on PW Med. My name is Dr. Santosh Patel, and today we are going to learn about the Guillain-Barré syndrome, or what we colloquially call as GB syndrome. Okay, now GB syndrome, when we talk about it, there are few areas from which MCQs have been repeatedly asked, and this is one of the topic which can be frequently asked also during your bedside discussion. Okay, so let us understand how do we define GB syndrome, what is the etiology, what are the clinical features, or in other words, how these patients present to us, what are the causes for mortality, and how we manage a patient with GB syndrome, right? So let me start by asking you to define GB syndrome for me. Or in simple words, let me say, we have learned about the localization of lesions in neurology, right? We know how to identify a disorder of muscle, how to identify a disorder of neuromuscular junction, how to identify a disorder of peripheral nerve, how to identify a disorder of the spinal cord, the brainstem, subcortex, as well as cortex, right? So now in this whole hierarchy, where do you want to place the site of lesion in patients with GB syndrome? Is it a disorder of muscle, neuromuscular junction? Is it a disorder of the peripheral nerves, or is it a disorder of the spinal cord, subcortex, brainstem, cortex? What is it? So that is where our discussion should begin. What is the site of lesion in a patient with GB syndrome? Are we talking about a muscle disorder? Are we talking about a neuromuscular junction disorder? Or are we talking about the disorder of the peripheral nerves? What is it? E. Chandrapatra, absolutely right. So GB syndrome is a peripheral nerve disorder. Okay. Now, when I say talk to me about peripheral nerve disorders, I think most of the students should first talk about diabetes. So in diabetes, what happens? The glycated end products, like you have this HbA1c, similarly, various other tissue proteins become glycated and they cause damage to neurons. And that is why we end up developing neuropathy. Now, what is the reason for neuropathy in a patient with GB syndrome? So let us begin by defining GB syndrome. GB syndrome, I would define it as an infection triggered. See, I'm not saying infection is the direct cause, right? That's why I'm using the term infection triggered. Infection is merely triggering the sequence of events leading to development of GB syndrome. Infection triggered inflammatory polyneuropathy. Polyneuropathy. Please pay attention to every word that we are mentioning in the definition, because that holds the key to our understanding of the disease. It's an infection triggered inflammatory polyneuropathy presenting as acute, rapidly progressive, okay. Now here is a question. Let us pay back to the definition. It's some infection is triggering inflammatory events, right? Those inflammatory events are responsible for causing the damage to peripheral nerves, right? Now here I am saying polyneuropathy. Now what does that mean? It is not selectively targeting one peripheral nerve, right? It is diffusely targeting, or in other words, generally it is targeting all the components of your peripheral nervous system. That means the nerve roots and the spinal nerves as well as cranial nerves. See, when we say peripheral nervous system, what all comes under it? Cranial nerves and spinal nerves. Both of them are being targeted by the inflammatory process which is initiated by the infection. Now, such a patient, how should he present to us? So peripheral nerve disorder, right? So when we talk about peripheral nerve, what all components are there in a peripheral nerve? Like that may be a spinal nerve or the cranial nerve. Just talking about peripheral nervous system, right? To pick up any one, pick up a cranial nerve or pick up a spinal nerve. What are its components? It will have one motor neuron, right? It will have a motor neuron. It will have a sensory neuron, and it will have autonomic neurons, right? Autonomic neurons. So when motor neurons get affected, what is the consequence? The patient will develop weakness. Now in peripheral nerves, right, be it cranial nerves or the spinal peripheral nerves, in the peripheral nervous system, what kind of motor neurons we get? We get the lower motor neuron. So we are primarily talking about lower motor neuron being involved, right? So when lower motor neuron gets involved, as such, any motor neuron getting involved, we will develop the weakness. We will develop the weakness. Okay. The involvement of sensory neurons will lead to sensory deficits, right? You will lose some sensations, sensory deficits. And diffuse involvement of the autonomic nervous system means it is not selectively affecting only one nerve, giving rise to some localized autonomic symptoms. It is a polyradiculoneuropathy, so affecting multiple nerve roots and nerves. So systemically speaking, it is affecting your whole autonomic nervous system. So that can also lead to consequences like orthostatic hypotension. Orthostatic hypotension. Now I'm expected to see these features. Patient will develop weakness, he will have some sensory deficits, and he may develop autonomic symptoms, mainly in the form of orthostatic hypotension and tachycardia. Okay. Now the question is whether the weakness will affect proximal group of muscles or the distal group of muscles. And you should give me the answer to this. Weakness will affect proximal group of muscles or the distal group of muscles. So when we studied about the peripheral nerve disorders in one of the earlier modules where we discussed about neurological causes of paralysis, I told you longer the nerve, more likely that it will get affected by the pathologies, right? So that is why peripheral nerve disorders cause distal weakness, right? Agree on that? So apply the same concept here. Longer the journey of the nerve, earlier it is going to get involved in a patient with GB syndrome. So now, which body part is supplied by the nerves taking a longest course? Lower limb more than upper limb, right? Distal more than proximal. And again, in terms of limbs, lower limb more than upper limb. So the neurons going to your feet have the longest journey, and they will be the ones which will get affected first. So your feet is going to go weak first. Okay. After that, probably your leg muscles, then your thigh muscles. So when you apply that as a generalized picture, right? Think of a patient who first developed weakness of the feet, then the legs, then the thigh. So how should I describe this weakness as? Can I call it as ascending paralysis? Feet से शुरू होके ऊपर की तरफ बढ़ रहा है. So we can call it as ascending paralysis. Got the point? Why is it ascending paralysis? Because the longer the nerve, earlier it is to get affected, and that is why distal most body parts become weak first. So we will develop rapidly progressing ascending paralysis. Okay. Now, when I examine this patient's deep tendon reflexes, GB refers to Guillain-Barré syndrome. The name of the disease is Guillain-Barré syndrome. You can pronounce it in an Indianized way as Guillain-Barré syndrome or Guillain-Barré syndrome. No, it is symmetrical. Nizam Ajmal, it affects, see, as I have told you, it is a polyneuropathy. So it is not selectively affecting one limb, right? It is affecting all your neurons, length dependent involvement. So that is where the distal most body parts are getting affected first, but bilateral. It is usually going to be symmetrical. Okay, so when I examine these patients' deep tendon reflexes and the tone, what findings I should get? Distal weakness we understood. When I examine the tone, it is a disorder which is affecting lower motor neuron. So what should happen to the tone? When upper motor neuron gets damaged, tone increases, right? Deep tendon reflexes get exaggerated. Upper, everything up. Lower, tone decreases. Deep tendon reflexes decrease, right? So it is an infection-triggered inflammatory polyradiculoneuropathy presenting as acute, rapidly progressing ascending paralysis. And behind this, I want to use a term. Should I use flaccid? Should I use spastic? Or should I use rigid? Yes, so there will be hypotonia. So what should I write here? Flaccid, spastic, or rigid? So flaccidity is the term used for hypotonia, right? So these patients typically present with rapidly progressing flaccid ascending paralysis. Absolutely right. Rapidly progressing flaccid ascending paralysis. So this is the definition of GB syndrome. Okay, obviously from the definition we understand a lot about the disease. First thing that we need to understand is that which infection is responsible, how infection is linked to the inflammation of the peripheral nerves, right? So then comes the next question. What are the common implications which are implicated in causing GB syndrome? The first point to note here is that it is generally gastrointestinal tract infections are most commonly implicated, followed by the respiratory infections, GIT infections, followed by respiratory infections. Now, what are the common GIT infections which have been known to cause the GB syndrome? The first thing that should come to your mind, in fact, most of the MCQs that start with the infection leading to GB syndrome talk about this organism. What is that? So, Tapa Samantha, yes, it is a bilateral symmetrical lower limb weakness. Ascending up is how these patients present. Okay. So, Campylobacter jejuni is the most common infection responsible for initiating the pathological events responsible for GB syndrome. Can anybody tell me how this Campylobacter jejuni infection is usually acquired by humans? What is the most common method by which we get this infection? Nizam Ajmal, absolutely right. Campylobacter jejuni causes dysentery, right? Dysentery means diarrhea with blood in stool. It causes dysentery. Most often, we acquire this infection by improperly cooked poultry products. Means it could be egg as well as the chicken. So improperly cooked poultry products is the most common way we acquire the Campylobacter jejuni infection. Okay. What other infections are known to cause? The respiratory infection list is long. H1N1 is known to cause. HIV as is known to cause, right? Apart from that, in the recent times during COVID, even COVID-19 has led to multiple cases of GB syndrome, right? Other than that, Epstein-Barr virus infection is also known to cause. Now, what is the natural course of the disease? Typically, what happens once you have the Campylobacter jejuni infection, right? Campylobacter jejuni dysentery. It takes around 2 to 3 weeks period. During this period, probably because of molecular mimicry, body starts producing antibodies. The antibodies are supposed to destroy the Campylobacter jejuni, but because of molecular mimicry, they start damaging your neurons. So they will ask you what class of antibodies we see. The class of antibodies we see is IgG antibodies. IgG antibodies against gangliosides, which are essential components of our peripheral nerves, against gangliosides. So these antibodies will start causing the damage to peripheral nerves, damage to peripheral nerves, and that results in patient presenting with rapidly progressing ascending paralysis, rapidly progressing flaccid ascending paralysis. Okay. Now, can I call GB syndrome as an autoimmune disorder? Why not? Because there is involvement of antibody production. They have asked this MCQ, which class of antibodies are involved? It is the IgG class of antibodies which are responsible. So what MCQs they will ask you? What is the most common infection? It is the Campylobacter jejuni. Which system infections are most commonly responsible? GIT infections are most commonly responsible. What is the natural course of the disease? After developing dysentery, it takes around 2 to 3 weeks time for us to start seeing the clinical manifestations. Why 2 to 3 weeks time? Because IgG antibodies do not appear immediately. The first antibodies that appear are IgM. Once the IgG antibodies appear, then we start seeing the clinical features. Okay, clear? So Samantha, so when you develop dysentery, right, you get infected with, let me say, Campylobacter jejuni. Now, exact mechanism we are not clearly understood, but the proposed hypothesis is there is molecular mimicry. Now, what do I mean by molecular mimicry? If this bacteria has some protein which is structurally similar to another protein on the neuron, then antibodies produced against bacteria will also target the target the neurons, because they fail to differentiate between the bacteria and the neurons. That is how our own antibodies start damaging our own neurons. That's why we can also call it as an acute autoimmune disorder. Okay. Now, what clinical features I would expect in these patients? As we just understood, the most common presenting complaint is going to be rapidly progressive ascending flaccid paralysis. Rapidly progressive ascending flaccid paralysis. Obviously, that affects or starts in the lower limb first and then maybe involve the upper limb. Okay. Along with that, there are a few more points for us to understand. Will it involve the bladder, and will there be sensory symptoms, right? As we just understood, peripheral nerves have sensory neurons, autonomic neurons, as well as motor neurons. So motor neuron involvement is one which is presenting as ascending paralysis, but sensory neuron involvement is also there, right? So that means there will also be ascending sensory weakness, ascending sensory deficits. Okay. And because there is also involvement of autonomic neurons, there will be orthostatic hypotension and resting tachycardia. Orthostatic hypotension and resting tachycardia. Resting tachycardia. What is the reason for orthostatic hypotension and resting tachycardia? It is due to autonomic nervous system involvement. Okay. Now one question, will there be involvement of cranial nerves? The answer is yes, because peripheral nervous system comprises of both cranial nerves and spinal nerves. And when a disease affects peripheral nerves, it may as well affect the cranial nerves. So there may be involvement of cranial nerves. Then comes a question, what is the most commonly involved cranial nerve? What is the most commonly involved cranial nerve? GB syndrome can affect the cranial nerves. Most commonly affected is the facial nerve. And the second most commonly affected cranial nerve is going to be the third cranial nerve. Third cranial nerve. Clear? So very often patients with GB syndrome may have bilateral facial drooping as well as the third cranial nerve palsy. Okay. Now when I examine these patients, you should only tell me what is the most important differential diagnosis. Think of an individual who had dysentery and after that he's developed rapidly progressing ascending paralysis. So now you are seeing a patient who predominantly has lower limb weakness, right? It started in the lower limb and progressing upwards. So can I call it as paraplegia? Yes, I can call it as paraplegia, right? When two lower limbs are involved, we call it as paraplegia. And when we think of paraplegia, ideally what should come to our mind first? The spinal cord involvement, right? Spinal cord involvement. So then how do I differentiate between a patient having spinal cord pathology presenting as paraplegia and a patient having GB syndrome presenting as paraplegia? Because both of them are presenting with lower limb weakness. Yes, the examination findings are going to help us differentiate. Okay, I think I probably forgot to tell you, will there be bowel and bladder involvement in a patient with GB syndrome? You may say, sir, bowel and bladder involvement is classical finding of the spinal cord, right? Spinal cord involvement. But please remember the bowel and bladder, the intestines are supplied by the autonomic nervous system, right? And ANS involvement can also impair your bowel function. And you know that the bladder is supplied by the spinal nerves. So involvement of the spinal or peripheral nerves can also impair the bowel and bladder function. So you can have bowel and bladder dysfunction even in patients with GB syndrome. So this point is not going to help you to differentiate between a spinal cord paraplegia and the paraplegia due to GB syndrome. So is it possible? Yes, but there is one point that can help you. Late involvement. So in case of spinal cord involvement, if I suddenly cut the spinal cord, right? If I cut, let me say I cut the spinal cord at T10 level, then the bladder dysfunction is immediate. From there itself, the patient has bladder dysfunction. From there itself, patient has got anal incontinence. But GB syndrome, when the ascending paralysis becomes more severe and ascends further upwards, then only you will start see the bowel and bladder dysfunction. So that is one point you need to remember. Samantha, for some, there are two, three possible reasons. The facial nerve has a very long course, and as I told you, longer the course of the nerve, it gets involved early. And second, these IgG antibodies have the tendency to pass into the CSF. And because of that, the nerves which are bathed in CSF are more likely to get involved. The third cranial nerve is very much in contact and gets continuous contact with the CSF, so it becomes more vulnerable. Okay, so on examination, what all we will be looking for? Yes, as we know, this patient will have paraplegia. And on examination, we will look for the deep tendon reflexes and the tone, right? So when we look at the tone, what will we find and what will happen to the deep tendon reflexes? As we just know, the tone will be reduced, right? Reduced. So what do we call it as? Placidity. and deep tendon reflexes will be diminished. So what should we call it as? It may be even absent if the disease is severe. So what should I call it as? Hyporeflexia or areflexia. Hyporeflexia or areflexia. So let me give you a quick summary again. GB syndrome is an infection-triggered autoimmune disorder. Infection is triggering the autoimmunity. IgG antibodies are being produced, which are targeting gangliosides. Gangliosides are predominantly found in the peripheral nervous system. So peripheral nerves are the ones which are being targeted. And as we know, peripheral nerves, depending on their length, they get affected. Longer the neuron gets affected the early, and that is why the weakness starts in the distalmost parts and then starts ascending upwards. Okay. Now, because peripheral nerves also contain autonomic neurons and sensory neurons, we can have the sensory system involvement. So not only ascending paralysis, but also ascending sensory loss. And we can have autonomic nervous system dysfunction presenting as orthostatic hypotension and resting tachycardia. Okay. Now, can a patient with GB syndrome die? Nilanjana, good. Can a patient with GB syndrome die? Will I die if my legs become weak? Not directly. Will I die if my legs become weak? Not directly. Dr. Putinmate, one point I forgot to address. Spinal cord paraplegia. So when I cut the spinal cord, right, only at the level of damage, I'm causing the damage to lower motor neurons. Otherwise, I'm predominantly causing the damage to upper motor neurons. So when upper motor neurons are damaged, what will happen to the tone and deep tendon reflexes? Exaggerated, right? So spinal cord paraplegia is spastic paraplegia, increased tone with paraplegia. GB syndrome paraplegia is flaccid paraplegia, right? Decreased tone with paraplegia. This is the point that helps you to differentiate. So that is why whenever you go to the ward and see a patient with paraplegia, if I'm the faculty, all I would see is how well you document the tone and deep tendon reflexes. If you can prove that the tone and deep tendon reflexes are diminished, yes, you have a case of GB syndrome. If you say that the tone and deep tendon reflexes are exaggerated, then you have a case of paraplegia because of the spinal cord damage. Yes. See, orthostatic hypotension, I think we have discussed about it when we spoke about the syncope, right? So normally what happens when we stand up, because of the gravitation, there is pooling of blood in the lower limb veins. So that has a tendency to drop the BP. To correct that, our autonomic nervous system gets activated. It causes vasoconstriction, pushes more blood to the heart and increases the BP. So autonomic nervous system is primarily responsible for the correction of BP on standing. But if you have autonomic nervous system dysfunction, then you will not be able to correct it and the BP will drop. And then patient can feel dizzy on getting up. That's what we call as orthostatic hypotension. Now resting tachycardia. So as you know that heart rate is controlled by balance between the sympathetic and parasympathetic nervous system, right? Sympathetic tries to push the heart rate, parasympathetic tries to decrease. Okay. So when there is damage, this balance can be tilted. So when the balance is tilted, you no longer have the heart rate in the normal range of 60 to 100. It can be more than 100 at rest when I'm not doing any physical activity. Normally, when I'm doing physical activity, it can increase. When I start running or when I start lifting weights in the gym, heart rate increases. That's natural. But at rest, only these people's heart rate will be higher because of imbalance between the sympathetic and parasympathetic nervous system. Okay. Yes, GB syndrome patients often die, and the reasons for death, there are two possible reasons. Number one, as the ascending paralysis ascends further up, there can be involvement of the diaphragm and the other muscles of respiration. So that can lead to respiratory paralysis. That is one. In the past, that used to be the most common cause for death in patients with GB syndrome. Today, it is not a big concern. Why it is not a big concern? Because the ascending paralysis reaching the diaphragm or the respiratory muscles, we have a simple solution. Put the patient on ventilator till he recovers from the GB syndrome. So respiratory paralysis may not be a concern. But the problem is ventilator brings in its own set of complications. What complications? I think you are familiar that ventilation, mechanical ventilation can cause volume trauma and barotrauma if you are not choosing the right setting. Apart from that, infections are very common in ventilated patients. We call it as ventilator associated pneumonia. So collectively, all this are in simple words, respiratory complications, which include respiratory paralysis and complications of mechanical ventilation, collectively are responsible for majority of deaths in GB syndrome. So when it comes to GB syndrome causes for mortality, the first one is respiratory complications. That is the most common cause. And when I say respiratory complications, yes, I'm referring to respiratory paralysis or failure and other complications of mechanical ventilation related complications. Okay. Now there is one more dreaded complication that is like more worrisome. See, a ventilated patient, I'm familiar, right? Okay, now I have put the patient on ventilator. I know that complications are possible. I would be priming the attenders that we should be watchful of these complications. We're doing our best, but it's unpredictable. When he will develop a ventilator associated infection, I don't know. Right? But sometimes a complication can strike with no warning, and that is related to autonomic nervous system. Because now we have lost control on the autonomic nervous system, we have lost control on the cardiac conduction system. So we don't have the regulation on the heart rate anymore. So sometimes it can lead to fatal arrhythmias. So the second important cause for mortality is the cardiac arrhythmias. Now, which kind of cardiac arrhythmias can cause death? Which kind of cardiac arrhythmias can cause death? Mostly atrial fibrillation or PSVT will not lead to death that easily. But there are certain arrhythmias which are really fatal. Those are ventricular arrhythmias. That is ventricular tachycardia and ventricular fibrillation. So these are the two complications which are responsible for majority of the deaths. Among them, the most common one is the respiratory complications. Clear? Okay. So now, one last question I have before I take you to the diagnosis and management. Okay, so if I get a patient with GB syndrome today and I treat him effectively and send him home, what is the likelihood that he will keep coming back again with repeated episodes of GB syndrome? What is the likelihood that he will keep coming back with the repeated episodes of GB syndrome? Is it like half of the patients will come back, 75%, 25%? How many of these will come back with GB syndrome? So remember, GB syndrome is a monophasic illness. Now, what do I mean by this when I say monophasic illness? Means recurrence is rare. Recurrence is rare. Less than 5% of the cases. So even if the patient whom I am dealing with now having GB syndrome because of Campylobacter jejuni infection, if he develops one more Campylobacter jejuni infection in the future, the chances of him developing GB syndrome is quite less. So it is kind of, I would say, once in a lifetime event. And understanding this is crucial because there is one more condition which is called as chronic inflammatory demyelinating polyneuropathy. Chronic inflammatory demyelinating polyneuropathy. So this GB syndrome is an acute polyneuropathy, but there is also a similar condition called as CIDP, where patients go on experiencing repeated episodes of demyelination. So they have repeated attacks of demyelination presenting to hospital with peripheral nerve symptoms. So we have to differentiate that from GB syndrome. So GB syndrome is unlikely to recur. So if you get a patient whom you are diagnosed and treated as GB syndrome and he comes back again with another episode of demyelination, I wouldn't think of that as GB syndrome. Then I would rather think that, okay, probably I had misdiagnosed a case of CIDP as GBS when we presented last time. And mostly now that it is becoming clear that it is a case of CIDP. Recurrence is very, very rare in a patient with GB syndrome. Okay. So then as a doctor, what is my biggest challenge? See, patients of GB syndrome can die if the paralysis ascends up to involve the respiratory muscle. So I should make all possible efforts to make sure that it doesn't reach the respiratory muscles. Once it reaches the respiratory muscle, I don't have a choice but to put the patient on ventilator. And once I put the patient on ventilator, other complications I may not have the full control on, right? So I should make all possible attempts to prevent the progression of the GB syndrome to involve the respiratory muscles. Beyond that, rest of the things are not in my hand. But if I prevent the progression, or let us say it progresses and patient is on ventilator, then I should make all possible attempts to minimize the complications. And if I handle him well during this period of ventilation, usually by third or fourth week of GB syndrome, they start showing the good signs of recovery. And if I can make him survive for 4 or 5 weeks, after that, the chances of death are minimal and the patient will definitely walk home. Right? So then what are the key points that will help me to make the patient walk home and not go to the mortuary? Simple. Make the diagnosis early, right? And try to treat effectively so that you prevent the involvement of respiratory muscles. If respiratory muscle involvement happens, promptly put him on ventilator and try to minimize the complications related to ventilator. And hopefully the nerves will recover and he will go home. Now then, how do I make an early diagnosis, right? So any patient presenting with rapidly progressing ascending paralysis by default should be considered as a case of GB syndrome, and then we make a diagnosis. Now for diagnosis, there are several criteria that can be used. Okay, so I will list two criteria which are commonly used. One is called as NINDS criteria, and the second one is Brighton's criteria. Brighton's criteria. You don't need to get deep into these criteria, but the names is something that you need to remember. Okay, and I will take you through the NINDS criteria because in current context, mostly we follow NINDS criteria for the diagnosis of GB syndrome. Please pay attention to what points we're going to discuss now over next 7-8 minutes, because half of the MCQs asked on GB syndrome are centered around the points that we're going to discuss now. Okay. So according to this NINDS criteria, there are three parameters that we have to discuss. One, the necessary points for the diagnosis of GB syndrome. Like these should be there to consider you start even thinking about GB syndrome, right? After that, there are some features which support the diagnosis of GB syndrome. Like in addition to the essential components, if these are there, good, that you can be more confident about your diagnosis of GB syndrome. And then there are certain features which go against the diagnosis of GB syndrome. They may be pointing towards something else. So we should be aware of these points. Why am I emphasizing on this? Because when MCQs are constructed, generally MCQ goes like this. Which of the following finding or which of the following feature is not in favor of the diagnosis of GB syndrome? Or which of the following finding is inconsistent with the diagnosis of GB syndrome? These are the kind of MCQs that we generally encounter. Or sometimes they build a story of patient like symptoms, findings, and then they will ask you which of these patients' findings do not support the diagnosis of GB syndrome. So that is why understanding this is important. So first, let me take you through this features required for diagnosis. Pretty simple, right? We already put these points in the definition. GB syndrome is a peripheral nerve disorder, and when peripheral nerves involved, lower motor neurons, sensory neurons, and autonomic neurons are involved. Involvement of lower motor neuron causes weakness. Starts with the distal most body parts. Feet being the distal most body parts, that's where the weakness starts, and then starts progressing upwards, right? So progressive weakness of muscles of more than one limb. So if only one limb is involved, I think you might have pointed earlier also, right? That whether there is bilateral or unilateral, it has to be more than one limb involvement. Generally, it is bilaterally symmetrical involvement. So progressive weakness of muscles of more than one limb. And on examination, we have to prove that this is a peripheral nerve disorder, and our best proof comes from the proof that there is lower motor neuron damage. So when lower motor neuron gets affected, there will be diminished reflexes or absent reflexes. These are the essential features for the diagnosis. These should be there. So if I have a patient with ascending paralysis, but there is no hyporeflexia or areflexia, I can't call it as GB syndrome. I have to take it away from the differential diagnosis, start thinking of spinal cord pathologies. Okay. Then what point support the diagnosis of GB syndrome? Important points here. One is progressive phase. Means see, once I have Campylobacter jejuni infection, 2 to 3 weeks, I won't have any symptoms. I had a dysentery for 3-4 days. I settled. Next 2 to 3 weeks, I don't have any symptoms. Then rapidly progressing ascending paralysis starts. This ascending paralysis, as long as it is progressing, right? It started in the feet, then the legs, then the thighs, then the pelvic region. It is ascending. So this progression generally lasts for maximum of 4 weeks. That's why I say that at the end of 4 weeks, a patient with GB syndrome should either be getting ready to go home or should be going towards the mortuary. He should not be still in the progressive phase. Like to give you an example, like okay, week 1 I had a weakness of feet. Week 2 I had weakness of legs. Week 3 I had weakness of thighs. Right? Week 4 I have weakness of the pelvic region. Week 5 there should be no further progression. Progression in GB syndrome stops within 4 weeks. So in week 5 or week 6, I still have progressing weakness. Then probably it is not GB syndrome. It may be something else. Most patients their maximum weakness is evident within 2 weeks of the onset of symptoms. By third or fourth week, they start showing the signs of recovery or signs of improvement. So if I have a patient who is continuing to progress beyond 4 weeks of the onset of symptoms, then it is mostly pointing towards another differential diagnosis called as chronic inflammatory demyelinating polyneuropathy or CIDP. That is why progression beyond 4 weeks doesn't support. Progressive phase lasting for less than 4 weeks supports the diagnosis of GB syndrome. Then this point you people were asking whether it is unilateral or bilateral, right? The relative symmetry, both the limbs being kind of equally affected, supports the diagnosis of GB syndrome. Why is it? The answer is pretty simple. See, this is an autoimmune disorder. Now, antibodies cannot be very selective, right? Like antibodies produced in systemic circulation won't say like, okay, I will only affect the right side of the body or I will only affect the left side of the body. They will generally affect both the sides equally. So most patients will have relatively symmetrical symptoms. Okay. Then coming to sensory involvement. So when we spoke about the spinal cord disorder, we learned there that when I cut the spinal cord, I get a sharp sensory level, and which segment of the spinal cord is cut, I can understand by looking at the dermatomal level of the sensory involvement, right? But in GB syndrome, we don't get that sharp sensory level. The sensory involvement here is mild. Means patient will say that I don't have any sensation in the feet, legs, maybe thighs, but he cannot pinpoint to a dermatome and say that, sir, beyond this, I don't feel any sensation. Above this, I can feel the sensation. Such a sharp sensory level is not encountered in a patient with GB syndrome. Clear? Okay. Then cranial nerve involvement favors or supports the diagnosis of GB syndrome because cranial nerves are part of peripheral nervous system and GB syndrome is a disorder of peripheral nervous system. You don't get cranial nerve involvement in a patient with spinal cord paraplegia, right? Autonomic dysfunction present means you have orthostatic hypotension or resting tachycardia that supports the diagnosis of GB syndrome. Okay. Then mild pain of the affected muscles or the radicular type of pain. Now, what do I mean by radicular type of pain? You know that when you study the spinal cord, right, you have this spinal nerve roots, right, coming and then forming a spinal nerve. These are what we call as spinal, like ventral rami and dorsal rami. They are called as spinal roots. So when some damage happens to these roots, the pain is a radiating type of pain. The pain radiates along the distribution of that spinal nerve. So if you have a similar pain, that again favors the diagnosis of GB syndrome. That's why when we spoke about the diagnosis, I said not only polyneuropathy, I have written polyradiculoneuropathy because these antibodies are not only damaging these nerves, they are also damaging the nerve roots. So it's a polyradiculoneuropathy, radicals as well as the nerves being affected. And because of the radicular involvement, you can have kind of shooting type of mild pain in these patients. Okay. Now, these antibodies that are produced against the gangliosides, they do often reach the CSF. And antibodies are what? Primarily IgG. IgG is what? It is immunoglobulin, which is what? It is a protein. So if extra proteins are added to CSF, then what will happen to CSF protein? It will be increased. So increased CSF protein also supports the diagnosis of GB syndrome. Okay. Apart from that, we can do the nerve conduction study to prove that it is a neuropathic disorder. So these are all the features which are favoring the diagnosis. Again, summarizing, the progressive weakness and hyporeflexia, areflexia are must for diagnosis. The other features that I just listed support the diagnosis, but there are some points which actually refute the diagnosis. If these are present in a case, it is most likely not GB syndrome, but something else. What are these? The first point to note here is nadir within 24 hours. Now you may be thinking, what is this nadir? Nadir means the lowest. So the usual what happens, the patient with GB syndrome, the symptoms start, it progresses rapidly, peaks like before 2 weeks of time and then start showing the improvement. But if the patient peaks within 24 hours, like within 24 hours is maximally weak, right? Morning I have the weakness of the feet and in within a period of 24 hours, I have the weakness has reached my thoracic level. It can't be GB syndrome. It is most likely because of the spinal cord pathology. Okay. Then I have already told you progressive phase lasting for more than 4 weeks points towards chronic inflammatory demyelinating polyneuropathy and not GB syndrome. Then presence of a sharp sensory level where patient can pinpoint and say that, sir, I don't feel any sensations below this level, above this level, I feel all. That's what we call as sharp sensory level. That always points towards the spinal cord pathology. In fact, in any question, if you come across sharp sensory level, it clearly means that the damage is to the spinal cord. Okay. Then extensor plantar obviously indicates upper motor neuron damage. And in a patient with paraplegia, upper motor neuron damage again points towards spinal cord damage. Similarly, exaggerated deep tendon reflexes, upper motor neuron damage again points towards the spinal cord damage, right? And then presence of fever may be pointing towards the muscle disorders, may be pointing towards the encephalopathies or even meningitis. So again, presence of fever at the time of presentation in a patient with GB syndrome is unlikely to be GB syndrome. So this is one table I want you to by heart because it keeps appearing in the MCQs, not consistent with the diagnosis of GB syndrome. Clear? Okay. Now that we have learned about the diagnosis of GB syndrome, two more steps. One is that there is further classification of GB syndrome into subtypes, and then about the management. We know that patients with GB syndrome are prone to die. GB syndrome is a monophasic disorder. So if they survive this attack, they survive. They're unlikely to get again and again attacks of GB syndrome. But survival during this attack is crucial because there are possible complications and they can die. Now, is it possible for me as a doctor to predict the possibility, like which patient is likely to have complications, which patient is less likely to have complications? Yeah, it is possible. How is that possible? Because there are different subtypes of GB syndrome, which we have understood once we started doing nerve conduction studies for the patients. So based on the nerve conduction studies, we have classified the GB syndrome into different types. But before going to the types, we will understand a little bit about nerve conduction study. Okay. So let me begin by asking you a question. You all know that we are talking about the myelinated neurons here, right? So like, let me say that this is a neuron and it has a myelin sheath. Okay, this neuron is going to eventually synapse with a muscle and is going to create a neuromuscular junction here. Okay, now in what ways I can damage this neuron? One way I can damage the neuron is I can literally destroy its myelin sheath. That is one way of causing damage. So antibodies can do that. Antibodies can destroy the myelin sheath. So when myelin is destroyed, we call it as demyelination. Okay. Then the other way I can destroy it is I can, instead of causing the damage to myelin sheath, I can cause the damage to the axon. Right. This, the initial internal portion is what we call as axon. So I can either cause damage to axon or cause damage to the myelin sheath. And nerve conduction study helps me to differentiate whether the damage is to the axon or whether damage is to the myelin sheath. Okay. Now you should tell me, if I cause damage to axon, recovery will be late, or if I cause damage to myelin sheath, the recovery will be late. Nilanjana, good point. Damage to the myelin sheath will be slow to recover, or damage to the axon will be slow to recover. It is the damage to axons which will be slow to recover, and that is why axonal injury carries poor prognosis. If I cause damage to the myelin sheath, the recovery will be relatively better and complete, and thus carries better prognosis. So on the nerve conduction study, if I can see a patient who has got demyelination, has a better prognosis. Some individual who has got the damage to axon, axonal injury, carries a poor prognosis. Now, how the nerve conduction study will tell me whether there is damage to myelin sheath or the axon, right? The concept is simple. What we have to understand is, in nerve conduction study, what we do, we stimulate this nerve by giving an electrical impulse. By giving an electrical impulse. Okay. And then we can measure two things. One, how forcefully this muscle contracts and how much time it took for the electrical impulse to reach or travel the distance. Okay. So from this, what will I understand? When I give electrical impulse, two things are there. One, I'm giving some voltage, right? I'm giving some fixed voltage. How much voltage reached the muscle and how much time it took to reach the muscle. Okay. So now, if I have myelin, will it reach faster or will it reach slower? If I have myelin, let me say I'm stimulating the nerve here. I have the myelin sheath. In presence of myelin sheath, will it reach faster or will it reach slower? Why do we need myelin sheath? For faster conduction, right? what is called as saltatory conduction, where an electrical impulse jumps from one node of transmitter to next to reach the destination quicker. So myelin sheath only function is to increase the speed of conduction. It has no influence on the voltage conducted. How much ever voltage you give, it will make sure that it gets conducted faster. Nilanjana, right? Okay. So if I have caused damage to myelin sheath, what will happen to the conduction velocity? If there is damage to the myelin sheath, what will happen to the conduction velocity? Obviously, that will be decreased. So if I have damaged the myelin sheath, then there is no longer saltatory conduction possible. Then the impulse has to get conducted through the entire demyelination of the depolarization of the axon, and thus it will be slow. So conduction velocity gets decreased when there is demyelination. Clear? Okay. Now, let me say my myelin sheath is fine. Okay. But I have caused damage to the axon. I have caused damage to the axon at multiple levels because of the antibodies. Now, what will happen? My conduction velocity will not be interfered, because as long as I have myelin, I have the saltatory conduction, so I will be able to conduct faster. Then what will get affected? The voltage. Because when I give an impulse here, right, at the sites of injury, the voltage gets dissipated. So voltage drops. So let me say that I am just giving you a hypothetical number. Let me say I'm giving 100 millivolts here. Okay. Then this 100 millivolts, when it reaches one site of injury, there will be some voltage dissipation or drop. So that will become 90 millivolts. In the next site of injury, it will further drop and it will become 80 millivolts. So finally, the amount of voltage that is being delivered to the muscle will be lower. Okay. Now, how will I calculate how much voltage I gave to the muscle? I know how much I gave here. How much was delivered to the muscle? How would I get to know? I cannot directly, or I won't directly measure the muscle voltage. But if I give the higher voltage, higher will be the force of contraction of the muscle. If I give lower voltage, lower will be the force of contraction of the muscle, right? How would I understand what is the generated force of contraction from the muscle? Primarily looking at the muscle's action potential. So the second parameter that we look at is the compound muscle action potential, called as CMAP. CMAP will be decreased whenever there is injury to the axons, because voltage keeps dropping at the site of injury. So we will give less voltage to the muscle. So muscle will generate lesser action potential. So these two parameters will help us to differentiate whether an individual has demyelinating injury or whether he has got a axonal injury. And based on the findings of nerve conduction study, GB syndrome is classified into two major groups. The first one is called as AIDP. The name stands for acute inflammatory demyelinating polyneuropathy. It stands for acute inflammatory demyelinating polyneuropathy. Demyelinating polyneuropathy. So in fact, previous definitions of GB syndrome used to go like this. GB syndrome is the demyelinating disorder. That's how we used to start. But since the advent of nerve conduction studies, we know that some GB syndromes do not have demyelination. Some have demyelination. Some have axonal injury. That's why no longer I put this demyelination word in the definition. Okay. Now AIDP, as the name says, it is a demyelinating variant. So in these patients, when I do nerve conduction study, right, you should tell me now what will happen to the conduction velocity. Here, damage is to the myelin sheath. So what will happen to the conduction velocity and what will happen to the compound muscle action potential? Yes. So conduction velocity, it will be decreased because it is a demyelinating disorder. But voltage is not lost. All the voltage that we have given in the nerve conduction study has gone to the muscle. So the compound muscle action potential will be normal, right? That will be normal. This is the typical picture of AIDP. Okay. Now, point to note here is that AIDP is the most common type of GB syndrome, and this is seen in this accounts for more than 85% of cases of GB syndrome. Okay. Now, what is going to be the prognosis of these patients? Nilanjana, what is the prognosis of these patients? I told you, right? Demyelination, recovery is complete and quick. So then that means these patients have good prognosis. So less likely that a patient with AIDP will progress to the stage of requiring ventilator. Chances are less. I don't mean zero, but chances are relatively less in comparison to other variants. So these patients have good prognosis. So in terms of prognosis, they have good prognosis. Okay. Nowadays, there is a trend of asking questions about antibody and their correlation with the type. Means I told these in GB syndrome, there are ganglioside targeted antibodies. But antibodies mean there are different specific targets for these antibodies. So they often ask you which antibody is most commonly found in this particular type of GB syndrome. So the most common antibody that we see in AIDP is going to be an antibody called as anti-GM1 antibody. Anti-GM1 antibody is the most common antibody that we see in patients with AIDP. AIDP carries good prognosis and it has demyelinating variant. Okay. The next variant that we are going to talk about is called as Aman, and there is one more variant which is called as Amsan. Amsan. Okay, now what Aman stands for? It's all there in the name. Aman stands for acute motor axonal neuropathy. It stands for acute motor axonal neuropathy. So from the name, you can tell me that this patient has got damage to the axon. So this is an axonal injury variant. Okay. Now this, what is this AMSAN? AMSAN stands for acute motor and sensory axonal neuropathy. Acute motor and sensory axonal neuropathy. So this is also an axonal injury variant. This is also an axonal injury variant. Now from this slide only, you should tell me, there is one GB syndrome variant where there is no involvement of sensory neurons. Generally what we say GB syndrome means there is involvement of lower motor neurons giving rise to rapidly progressing ascending flaccid paralysis with areflexia, and sensory neuron involvement giving rise to ascending mild sensory paralysis, sensory weakness, sensory deficit without sharp sensory level, and autonomic nervous system involvement giving rise to resting tachycardia or orthostatic hypotension. But then there is one variant which does not involve the sensory neurons. Which one is that? It is there in the name, right? Why are we calling Aman as Aman? Because it is one variant of GB syndrome where there is no involvement of sensor. See, everything else, we are not talking about not involving the sensory or only involving the motor. Nilanjana, in AIDP also, mild sensory involvement is pretty common. So it is the Aman, which is a pure motor variant. That's why in the name only we made it as acute motor axonal neuropathy. There is no involvement of the sensory neurons at all in AIDP. Miller-Fisher, we do have involvement of sensory. Okay, so now in Aman, if I do the nerve conduction study, see, Aman and Amsan are very similar. Both are axonal injuries. The only difference is that in Aman, it's only affecting motor neurons. In Amsan, it is affecting motor as well as sensory neurons. So in both of them, when I do nerve conduction study, right, what will happen to the conduction velocity and compound muscle action potential? What will happen to the conduction velocity and compound muscle action potential? Now, both will have the same nerve conduction studies, except that in AMSAN, you will also have sensory deficits on examination. Yes, because these are axonal injuries, the CMAP will be decreased. The compound muscle action potential will be decreased. No matter how much voltage I give, some amount of that will be dissipated at the sites of axonal injury and less voltage will be delivered to the muscle. So the action potential generated by the muscle will be less. But as long as I have myelin, in these patients, both I have myelin. So the conduction velocity will not be slowed down. So conduction velocity will be normal. Okay. Now what antibodies I would see, and about prognosis, what kind of prognosis I can expect in these patients? Nilanjana, right. So what kind of prognosis? Axonal injury generally carries poor prognosis. So it is the Aman and Amsan who have higher likelihood of progressing to require the ventilatory support. So generally these prognosis is poor in comparison to AIDP, but still better than the next variant I'm going to describe. So that's why I will call it as moderate prognosis. Moderate. I wouldn't call it as good because it is bad in comparison to AIDP, but there are some more variants which are even worse. So that we will discuss later. Okay. Now coming to what are the antibodies that we will see in these patients. The most common antibody that we see in these patients is anti-GD1A antibodies. Anti-GD1A antibodies. The anti-GM1 antibodies were seen in AIDP. In both AMAN and AMSAN, we get anti-GD1A antibodies. This anti-GD1A antibody is relatively specific. Means if I get a patient with anti-GD1A antibody, even without doing the nerve conduction study, I can say that this has to be either AMAN or AMSAN based on my clinical examination findings. Okay. Now we have one more variant, which is often even described as a separate disorder itself, which is called as Miller-Fisher syndrome. Miller-Fisher syndrome. Now, this Miller-Fisher syndrome is a condition where you often have a mixed pattern of injury, or some patients will predominantly have the demyelination pattern or the mixed pattern. So this could be either a mixed pattern. When I say mixed, what does it mean? Both axonal as well as demyelination. Myelin bhi gaya, axon bhi gaya, or some patient may just have demyelination. Okay. Now in these patients, if I do nerve conduction study, what am I going to get? What will happen to the conduction velocity if it is mixed? Forget about demyelination, which is rare. Commonly, it is mixed. So what will happen to the conduction velocity? And Cmax. Conduction velocity will be decreased because of the demyelination, right? And Cmax will be decreased because of the axonal injury. So both will be decreased. Okay. Now this variant is not very difficult to recognize. I don't need to go for the nerve conduction study. I can make a clinical diagnosis because this variant has some peculiar findings which are not seen in AIDP, AMAN or AMSAN. What are those peculiar findings? I think someone has already pointed out. Yes, these patients often have ophthalmoplegia and ataxia. Ophthalmoplegia and ataxia. Areflexia is part of any peripheral nerve disorders, right? So this has ataxia and ophthalmoplegia. Okay, so now the point is, what is going to be the prognosis of these patients? What is going to be the prognosis of these patients? So in terms of prognosis, these patients carry the worst prognosis because you have damaged myelin as well as the axon. So these patients carry the poor prognosis. So in terms of prognostication, I would say AIDP is the best. So if I am dealing with a patient with AIDP, I will be relatively calm. If I'm dealing with AMAN or AMSAN, I'm little concerned. If I'm dealing with a patient with the Miller-Fisher, I'm extremely worried because that carries very poor prognosis. So this nerve conduction study not only helps me to understand which type it is, but it also helps me to prognosticate. Okay. Last bit, what antibody we will see in these patients of Miller-Fisher. The antibody that we see in Miller-Fisher, see, in case of AIDP, it is GM1, which is not specific as such. In case of the AMAN-AMSAN, it is GD1A, right? In patients with the Miller-Fisher, it is going to be GQ1B, anti-GQ1B antibody. So there is one more variant which has the worst prognosis, which is a kind of an off variant. That's what I'm going to talk to you now. So what is GB syndrome? Is it a disorder of CNS or PNS? Antibody is anti-GQ1B in Miller-Fisher. Okay. What is the GBS? Is it a disorder of peripheral nervous system or central nervous system? It is a disorder of peripheral nervous system affecting cranial nerves and spinal nerves, right? But there is a CNS variant of GB syndrome, which not only peripheral nerves are involved, but even the central nervous system is involved. That carries the worst prognosis. So which variant is that? You can get anti-GQ1B in AMSAN, but it is less common. So it is typically GD1A is what you encounter in AMAN and AMSAN, and GQ1B is more commonly encountered in patients with the Miller-Fisher. Okay, so the GBS variant involving CNS. Can anybody tell me which GBS variant involves the CNS? So apart from peripheral demyelination, you also have demyelination of the central nervous system. So we call it as encephalomyelitis. So the condition is called as This can be an MCQ. The condition is called as Bickerstaff encephalomyelitis. Encephalomyelitis, and this carries the worst prognosis. Because even the central nervous system is getting demyelinated. Patients often become often dead or comatose and they can die. So that carries the worst prognosis. So in terms of prognosis, labeling it from best to worst, best would be AIDP, right, followed by Aman and Amsan, followed by Miller-Fisher syndrome, followed by Bickerstaff encephalomyelitis. So here the worst prognosis is Bickerstaff encephalomyelitis. Clear? Okay. So now we have understood what is GB syndrome. It is affecting what structures, what are the inciting events, and how once the paralysis happens, how it progresses, and why these patients have likelihood of. So when I have made a diagnosis of GB syndrome based on NINDS criteria, or maybe with the help of Britain's criteria, now the onus on the physician is that I should try to minimize the rate of progression so that respiratory muscles are not in. And if they get involved, then I have to put them on a ventilator and then try to minimize the complications coming out of ventilator. It's a very responsible job, because if I can make this happen, that patient does not develop any of these complications, then he is almost surviving and he will mostly go home with no deficits. The recovery in patients with GB syndrome is near complete. So patient won't go home saying that, okay, my power was 5 out of 5 when I started developing symptoms and now it is 3 out of 5. Patient will become completely normalized by the time they are ready to go home. So only thing is that I have to make sure that he survives this critical period, right? So it is only possible. Yes, Bickerstaff affects the central nervous system, because see, as we understood, these IgG antibodies, they are making their way into the CSF. So if the IgG antibodies quantity is very high, then we can have the CNS demyelination also. Then we call it as Bickerstaff encephalomyelitis. It's very, very rare, not well studied as such, because it is very rare, and we have not encountered much cases here in India, but we should be aware, especially from the MCQ standpoint. Okay, I forgot, because we are talking about it, right? I forgot one more point. So when we talk about diagnosis, one more often asked question is, what will happen to the CSF? I have already told you that IgG antibodies are going to CSF. So CSF protein will be elevated. CSF protein will be increased. Okay. What will happen to the CSF cell count? There is no role of cell-mediated immunity in the pathogenesis of GB syndrome. So CSF cell count will be normal. CSF cell count will be normal. So your protein is elevated, cell count is normal. What do we call this condition as? See, if I am dealing with a case of meningitis, whatever it is, bacterial, viral, fungal, if I have meningitis, cells will be increased, protein will be increased, right? If I have encephalitis, cells will be increased, protein will be increased. But now in this condition, only protein is increased, cells are not increased. What do we call this condition as? Yes, Nilanjana. The cells will be generally less than 50. So what do we call this condition as? This condition is called as albumino. Albumin here is referring to protein. Albuminocytological dissociation. Albuminocytological dissociation. Why are we calling it? Because normally albumin or the proteins in the CSF and cells follow the same direction. अगर protein बढ़ रहा है तो cells भी बढ़ेंगे, या cells बढ़ रहा है तो protein भी बड़ा होता है. They are all increased. They are going the same direction. But here protein is increasing, cell is remaining in the normal range. So there is a dissociation between the protein and cell. This is what we call as albuminocytological dissociation. Can you tell me in what other conditions you can get albuminocytological dissociation apart from GB syndrome? Apart from GB syndrome. Okay. Now coming to the management of GB syndrome. Our job is to minimize the antibody mediated injury to the axons or the myelin sheath. So how can I minimize it? I have to get rid of these antibodies. Can steroids be useful? No. Why? Because as I've already told you, in GB syndrome, the progression happens for a maximum of 4 weeks. So if I start steroids today, right, their efficacy on the B lymphocytes in terms of reducing the antibody production would happen 3 weeks down the line. So will they be useful? Probably no, right? So then how can I get these antibodies which are circulating and going and causing damage to the neurons come down? I reduce the antibodies, neuronal damage stops, so progression halts, and then existing damage will be healed. Demyelination, we will remyelinate. Axonal injury, we will regenerate. That is fine. So basically, I have to halt the progression by reducing the antibodies. How can we reduce the antibodies? Yes, so there are two ways, just like how we discussed in the earlier classes also, there are two ways we can bring down the circulating antibody load, right? One option is giving IV immunoglobulins, as Nilanjana mentioned, right? These IV immunoglobulins can neutralize the circulating antibodies that are targeting the myelin sheath or the axon. Second option is plasma exchange or plasmapheresis, plex or plasmapheresis. How does these work? Plex or plasmapheresis work by removing the antibodies that are in circulation. IVIG neutralizes, plex or plasmapheresis removes them. So we have two options to treat a case of GB syndrome. Among these, studies have shown that in terms of superiority, IVIG is slightly superior. IVIG is slightly superior to plasma exchange, but I think I've already also told you that IVIG is slightly superior to plasma exchange, not greatly superior. So the choice always is based on the circumstances. IVIG is expensive, plasma exchange is cheap. Plasma exchange requires expensive equipment. If you have it, good. If you don't have it in your setup, then maybe IVIG is the only choice. So depending on the circumstances, you can choose IVIG or plasma exchange. One of them, yes. We should not give both of them together. And if one fails, generally there is no role of trying other, because the mechanism of working both of them eventually is similar by reducing the circulating antibody load. Both of them reduce circulating antibody load. Okay. Now what about antibiotics? That's my last question. Should I give antibiotics? See, IVIG basically refers to immunoglobulins given in the IV form. From where these immunoglobulins are coming? These immunoglobulins are coming from other blood donors' plasma. So when we donate blood, right, the immunoglobulins can be extracted from them. So those immunoglobulins, if given to a patient with GB syndrome, they hold the capacity to neutralize these newly formed pathogenic antibodies. Yes, you can get albuminocytological dissociation even in patients with the multiple sclerosis. In multiple sclerosis also, it is the IgG antibodies which are causing the demyelination of the CNS. So there will be elevation in the protein and minimal or no elevation in the cell count. So you will have albuminocytological dissociation. Yes. So therefore, Samantha, both should not be given. And if you have tried IVIG, did not work, you should not be giving the plasma exchange treatment. Or if you have started plasma exchange treatment and it's not working, you shouldn't be doing the IVIG. Right? Okay. Now, the third thing that we have is to consider mechanical ventilation if patient develops respiratory paralysis. Mechanical ventilation if respiratory failure occurs. So till patient make a recovery, you have to keep them on the ventilator. Okay. Now the role of antibiotics. Should I give antibiotics to treat the Campylobacter jejuni infection? Should we give antibiotics to a patient with GB syndrome to treat the Campylobacter jejuni infection? What did I tell you? You get the dysentery. It takes 2 to 3 weeks for you to start developing the symptoms of GB syndrome, because IgG antibody has to appear. Then you start developing the nerve damage. Do you think by that time the Campylobacter jejuni infection would still be there in the individual? No, right? Campylobacter jejuni doesn't cause chronic diarrhea. It causes acute dysentery. By that time, your immune system would have taken care. In fact, your immune system, which produced antibodies against those bacteria, are the ones which are causing the damage to neurons. That means your immune system has already destroyed the bacteria. Unfortunately, they're continuing to destroy the neurons also. No longer infection will be active and there is no role of antibiotics. So the respiratory paralysis is seen because ultimately every muscle is involved in the respiration. It's predominantly a skeletal muscle. Okay. And in the GB syndrome, there is also involvement of cranial nerves. Okay. So now diaphragm, intercostal muscles, all of them are supplied by the spinal nerves, right? and some role of the vagus nerve. So eventually, when demyelination or external injury happens to these nerves which are concerned with the respiratory muscles, they will also become weak. So when they become weak, the patient will not be able to put in if sufficient respiratory effort, and then his depth of respiration and the respiratory rate starts dropping down. So he develops, to start with, he will develop the type 1 respiratory failure where you have hypoxia. Eventually, when the rate is very slow, he will not be able to even clear the carbon dioxide, and he will develop what we call as type 2 respiratory failure. This carbon dioxide also starts increasing. So in a patient with GB syndrome, regularly monitoring arterial blood gases is very, very essential, because you have to pick up that point where you have to make a decision that, okay, this is the time I need to put the patient on ventilator. Okay, so this is about our GB syndrome. One or two MCQs before we wind up. Okay, so here is the first question. Let us see if we can answer it. Which of the following is false about GB syndrome? Bowel and bladder dysfunction. Does it occur or not in a patient with GB syndrome? Bowel and bladder dysfunction. GB syndrome is a disorder of peripheral nervous system, right? And your bowel is okay. Yes, so it is a disorder of peripheral nervous system where there is also involvement of ANS, and your bowel is under the control of autonomic nervous system. You can have bowel dysfunction. Now, bladder is supplied by the spinal nerves. So when the peripheral nervous system get affected, it can get affected. So yes, there will be involvement of the bowel and bladder, but not early. It is a late involvement. Early involvement points towards spinal cord pathology, right? Sensory symptoms we have or no? We can have sensory symptoms, but it is generally mild and there will be no sharp sensory level. So if there is sharp sensory level, it points towards spinal cord pathology. Will we have flaccid paralysis? Yes, it is the disorder where there is involvement of lower motor neurons, so you will have flaccidity, right? Will we have areflexia? Yes, this is the disorder where there is involvement of LMN, so we will have areflexia. So sharp sensory level is something which is against the diagnosis of GB syndrome. So that becomes our answer. That is false. Okay. The next question, which of the following type of GB syndrome is a pure motor variant? We just discussed this point. I think Nilanjan had given the answer. Aman is a pure motor variant. We can have involvement in AIDP, Miller-Fisher, as well as AMSAN with respect to sensory involvement. Pure motor variant is Aman. Ataxic variant, that is one more MCQ they will ask you. Which of the following GB syndrome is of ataxic variant? That is Miller-Fisher syndrome. They will ask you which GB syndrome variant involves CNS, or which is a GB syndrome which is encephalitic variant, that is going to be Bickerstaff encephalomyelitis. So these are the MCQ points that you need to be aware of. So that's it from me today, guys. We'll be signing off. In the next session, we will start with stroke. Let me know if you want the stroke to be covered quickly in a succinct way, like we discussed the myasthenia gravis or GB syndrome, or you want me to split the stroke into different subcategories like the lacunar stroke, acute ischemic stroke, chronic ischemia and multi-impact dementia, and the hemorrhagic stroke, or all in one quick. Okay. So that's it from here, guys. I'll see you in the next session. Till then, see you. Okay.